Good afternoon, everyone. I am Ho Shik-sin, the director of the Transplantation Research Institute at Kosin University College of Medicine. Our university is a Christian university, so we begin our seminar with a prayer to God. Let us pray. Heavenly Father, full of love and abundant grace, thank you for placing us in a position where we can conduct research. Today, we gather for the 26th regular seminar of the TLI. May you guide us, our researchers and professors to serve both you and our neighbors faithfully. We pray that our effort will contribute to helping patients suffering from organ failure as we dedicate ourselves to our research. Today, we will listen to a lecture and engage in a discussion on the CAR T therapy for kidney transplant recipient. Please grant wisdom and clarity to our speaker so that they may teach effectively, and grant the discerning ear to the audience so that they may understand it well. We pray in the name of Jesus. Amen. We are deeply grateful to God for allowing us to host the 26th regular seminar of the TLI. I also would like to express my sincere gratitude to Professor Nauka for delivering today's great lecture, Professor Yan Sun-jung for chairing the session, and all the professors and colleagues from the within and outside the institute who have joined us today, and to Professor Hyung-Wan Moon and Kwang Il-seo, our research coordinator, for their dedicated effort. In particular, I would like to extend my thanks to Professor Naoka, who has been actively conducting research on transplantation and cancer-related topics, for kindly agreed to share their expertise with us today. Through the regular seminar, our research institute, we look forward to fostering active academic exchange and collaboration in research. Today's topic is the CAR T therapy for kidney transplant recipient. Will be presented by Professor Naoka, with Professor Yan Sun-jung chairing the session. I now hand over the session to Professor Zhang to proceed with the seminar. Please, Professor Zhang.
Good afternoon, everyone. Hi, Naoka. I'm pleased to introduce Dr. Naoka Murakami. Naoka means honest child in Japanese. Is it right?
Thank you for looking it up.
This honest child become a young and promising physician scientist. She earned her MD and PhD from the University of Tokyo. After completing nephrology fellowship in Brigham and Women's Hospital, and she joined the faculty of Harvard Medical School in 2019. She is currently assistant professor on the research track at Washington University. Her research supported by NIH grants. She has been honored with the Young Investigator Award from the AST and ISN. Dr. Murakami, please begin your lectures, please.
Wonderful. Thank you so much, Dr. Zhang, for a wonderful introduction. I'm very honored to be here. And then let me share my screen here. You see my screen? Okay. Is that looking good? All right. So thank you so much for having me. And I'm super excited to talk about the cellular therapies in kidney transplant, and transplant nephrologist by training. So I'll talk from the nephrologist standpoint. So the cellular therapies in transplant and cancer has been very much expanding for the past couple of years. And there are two categories of cellular therapy. One is the effector cell therapy, and the other is the regulatory cell therapy. So effector T cell therapy works by killing the target cells, whereby the regulatory cell therapy works by suppressing the target cells. So I'm going to start with a CAR T therapy for the cancer, especially the PTLD, post-transplant lymphoproliferative diseases. So as a brief review of post-transplant lymphoproliferative disorder, PTLD, they're mostly B-cell proliferative disease, typically driven by EB virus. And they're a wide spectrum disease presentation. So as a clinician, it's very important for us to be aware that, they can present from either asymptomatic, or they may have fever, weight loss, like B symptoms, or they can present as aggressive lymphoma. And PTLD comes with a bimodal distribution. There is early PTLD, which presents in 12 to 24 months post-transplant. They're usually ABV positive PTLD. And there's the other version of PTLD, which is late PTLD, which is usually diagnosed 5 to 10 years post-transplant, and mostly EBV negative PTLD. And so this is a very good article published in Blood, How I Treat Post-Lymphoproliferative Disorder, which is by Dr. Emengwal and Barbara Howe. So it's showing, diagnostic consideration and first-line therapy, and how to treat a relapsed PTLD and so on. So it's worth reading. So I highly recommend this. So let me introduce the concept of the CAR T therapy here. So CAR T therapy is the engineered chimeric receptor T cell therapy. So how it works is like this. So the patients get leukapheresis, and the white blood cells are collected, and ex vivo they're engineered to express chimeric antigen receptor CAR in the surface. And before the patients get the infusion of the CAR T cell therapy, they usually get the lymphodepleting chemotherapy, such as fludarabine or Cytoxan. And then a few days later, they get infusion of the CAR T product. So during that time, it's especially important for the transplant clinicians to know what to do about the immunosuppression. In order for the CAR T cells to be fully functional, we need to minimize the immunosuppression before infusing the CAR T therapy, which we'll talk about a little bit in detail later. So CAR T product evolve over time. So it initially started as a first generation CAR, which has the extracellular antigen binding domain, and then intracellular CD3 zeta activation domain, which started to be created around 2000, late 1990 or 2000 years. But in order to enhance the efficacy, there is a second generation of CAR, which has the co-stimulatory domain as an intracellular domain. So the second generation CAR has either CD28 or 4-1BB, OX40 or ICOS domain inside the intracellular domain, which greatly enhance the efficacy of the CAR Ts. The third generation has double intracellular co-stimulatory domain, but this third generation CAR T is too strong, and it can cause side effects such as cytokine release syndrome or neurotoxicity. So third generation CAR has not been used in a clinical setting. Right now, the fourth generation CAR T, which has a little bit of tricks inside the intracellular domain by adding cytokine or suicide gene, is potentially being used in a clinical setting as well. So with that, I'd like to highlight the difference between the CAR T therapy for non-transplant, regular kind of diffuse large B-cell lymphoma, DLBCL, versus PTLD on the right side. So there are 2 or 3 products that's already approved by FDA for DLBCL, Axi-cel or Lisa-cel. And their objective response rate is pretty good, 83%, and achieving 53% in the complete remission. But as I mentioned, there are remarkable side effects such as cytokine release syndrome or neurotoxicity called ICANS. So in contrast, the CD19 targeting CAR T has been approved for a PTLD, and the one meta-analysis showed the tumor response rate is 69% and then complete remission in 52%, which is a little bit lower compared to the non-transplant lymphoma patients, likely because the transplant patients are on immunosuppression, so that might have limited the efficacy of the CAR T therapy. Again, there are concerns about the concomitant immunosuppression, limiting the efficacy and persistence of the CAR T in the transplant population. And again, just wanted to highlight the challenges of using CAR T in a kidney transplant recipients. First is the T cell functionality. We learned from the translational experiments that the T cell phenotype of the CAR T matters. So after apheresis, it's important to check their T cell phenotype before moving on to the CAR T manufacturing. They check the T cell naive phenotype or central memory phenotype, and also these phenotypes are affected by the prior chemotherapy. The patient already had received the Cytoxan. They can change the phenotype of the T cells, and then also final CAR T product can be enriched by T central memory phenotype. That seems to be important to be more effective and then persistent. And also, when the patients are on the immunosuppression, they tend to be less proliferative during the ex vivo expansion. So that's another challenge. And the last point is that immunosuppression at the time of the apheresis can affect the T cell functionality, and then also the efficacy of the CAR T after the infusion of the CAR T product. So sometimes we completely stop the immunosuppression prior to the leukapheresis and restart the immunosuppression, maybe low dose prednisone after the CAR T infusion to keep the CAR T effective. And speaking about the side effect, cytokine release syndrome, CRS, or ICANS. So these frequency are similar to non-PTLD lymphoma. So cytokine release syndrome happens in 83% of the kidney transplant recipients with a PTLD receiving CAR T therapy, which is similar to non-transplant recipients. The data from ZUMA-7 or BELINDA, which is a DLBCL clinical trial. Similarly, the neurotoxicity happens in 60% of the kidney transplant recipient receiving CAR T therapy, which is similar to non-transplant population. In the meta-analysis, they showed a graft loss happened in 14% of the kidney transplant. And to overcome the negative effect of the immunosuppression on the T cells, there have been a couple of reports suggesting engineered, for example, FKBP knockout CAR T cell or glucocorticoid receptor knockout CAR T cells might be helpful to be more effective in the setting of the immunosuppression. So these new products might be proceeding to the clinical trial in the future years. So moving on to the virus-specific T cell therapies, VST. So opportunistic infection has been challenge for the clinical kidney transplant and all kinds of solid organ transplant. And, you know, for example, CMV virus infection, we have antivirus therapy. However, not all virus infection have effective antiviral therapies that, you know, cast the challenges in the clinical management. So there have been the virus-specific T cell therapy targeting multiple antigen, including EBV, CMV, BK virus, or adenovirus has been proposed and then used clinically. So as we saw in the CAR T production, the VSD is also produced ex vivo using the recipient's apheresed lymphocytes. So here we collect the PBMCs from the patients and ex vivo expand the T cells against the virus-specific antigens, and then we infuse the virus-specific T cells into the patients. More recently, in order to improve the accessibility to the VSD, there have been third-party VSD has been generated, which can potentially improve the accessibility and then also the efficacy. So in that case, instead of using the patient themselves PBMC, we can use the third parties PBMC as a source of the VSD. So we can always, you know, collect the T cells from third party and create the VSD and then store them in you know, -80 or like liquid nitrogen and be ready as almost immediately when they're needed. So this is kind of summary of the recent clinical trials using the VSD. They have been tested in a stem cell transplant population, as well as the solid organ transplant recipients. And then target viruses can be, you know, EBV or multi-virus VSD. And there have been great effect in terms of the objective response ratio, you know, ranging from 60 to 90%. And there have been more and more clinical trials published. So it's very exciting area to see for the next few years. And so then now we're moving on to the regulatory cell therapies. I'm going to start with a DC, regulatory DC therapy, and then talk about the Treg infusion therapy. So there are many kinds of different cell types which can have regulatory properties. There are, of course, T regulatory cells, which are very, you know, well-known CD4 positive suppressor cells. And there are also tolerogenic DCs that can be suppressive, can have a suppressive function. And there are also, you know, mesenchymal stromal cells or myeloid-derived suppressor cells, MDSCs, and the B regulatory cells have been also reported. So tolerogenic dendritic cells, tolerogenic DCs, is a special kind of cells that can produce the anti-inflammatory cytokines such as IL-10 or TGF-beta that can suppress the, you know, the T cells or cytotoxic T cells especially. And then these can be trained as a tolerogenic DCs by various conditions in the presence of low-dose GM-CSF or rapamycin, dexamethasone, or vitamin D3. So there's a very exciting clinical trial published in the Science Translational Medicine 2 years ago in liver transplant situation. So in this clinical trial, the liver recipient received regulatory DC that had been created from the donor. So what happened here is that the liver donor blood was leukapheresis and in ex vivo engineered as a tolerogenic DC in the presence of IL-4 GM-CSF, vitamin D3, and IL-10 for 7 days. And these tolerogenic suppressor DCs are infused into the recipient. So here's what happened. So in the study cohort, they created the DC reg prior to the liver transplant, and then they slowly taper down the mycophenolate and over the 12 months post liver transplant. So excitingly, in 12 months, so 1 year follow-up of immunological changes, the dendritic cell infusion was well tolerated, and there was no difference in the biopsy-proven acute rejection, and there was no difference in infection or the allograft function. So this is very exciting. And they also published the mechanistic analysis in this cohort. So when they compared the standard care and DC-REG study, they showed there are less cytotoxic cytokines circulating the blood in a study population who received the regulatory DC therapy, such as IL-12 or interferon gamma or 6-seroten. And if you look at the liver biopsy specimen in the study group compared to the standard care group, there was less CD3 or especially CD8 cytotoxic cell infiltrates in the liver parenchyma. So these are very promising that these DC-REG infusion might be able to induce the tolerance in the liver transplant setting. So how about Treg therapy? The Treg therapy has been trialed in a clinical setting for many, many years. So regulatory T cells are the CD4 T cells with a suppressing function, which express the FOXP3 transcription factor as a master gene regulator. And Tregs can be generated during the development in the thymus or in the periphery and then in vitro as well with appropriate cytokine co-stimulation such as low-dose IL-2 or TGF-beta. And importantly, if you lack Treg, it can result in an X-linked fatal autoimmune disease in mouse, such as scurvy mouse, or in a human as well, which is called IPEX, immune dysregulation polyendocrinopathy X-linked syndrome. So Tregs play a very important role in maintaining the peripheral tolerance and self-tolerance. It's also known to be very important to induce the transplant tolerance as well. So there have been various preclinical and clinical studies on Treg for tolerance in a transplant. Many groups tried to expand the antigen-specific Tregs to be expanded or engineered. They tried a polyclonal Tregs by co-culturing the donor splenocytes and the recipient T cells. But this polyclonal T cell approach, Treg approach, have only very few of the infused Tregs will actually be antigen specific. So we're kind of wasting more than 90% of the cells, not directly useful. And then there comes expanded antigen-specific T cells, but this requires the cross access to the alloantigen expressing cell. We need to have the donor splenocytes to make the antigen-specific T cells. So it's not easy to achieve in a clinical setting. Then there have been the transgenic T cell receptor approach, but it's very laborious to clone the personalized T cell receptors, and it's also MHC restricted. So it's very immunologically challenging in the setting of the kidney transplant or any kind of solid organ transplant. So there comes the engineering breakthrough of a chimeric antigen receptor Tregs, which are not MHC restricted, so that can potentially be promising approach in a clinical setting. So how does it work? So as I previously mentioned, polyclonal T cells are usually expanded using recipient Tregs stimulated by anti-CD3 and CD28, and these ex vivo expanded Tregs can be transferred to prevent rejection. Alloreactive Tregs can be expanded in the setting of the donor antigen-presenting cells like splenocytes and expanded and then transferred to the recipient. So CAR Tregs instead, they transduce the chimeric antigen receptor in the recipient-derived Tregs. And these are essentially clonal Tregs that can recognize the antigens from the donors. So the challenge here is that, in the transplant setting, target antigens are not fully analyzed, clear. So in this case, in panel C, they use A2, HLA class 1A2 as the target antigen, but it's not necessarily clear as in this case. And so, but regardless, compared to the polyclonal Tregs or alloreactive T cells, donor-specific CAR Tregs against HLA-A2 provided better protection than polyclonal Tregs. So these preclinical animal experiments is very encouraging to moving forward to the clinical trial. So currently, there is one clinical trial that is actively looking at the efficacy of the CAR Tregs in a human kidney transplant. So what they did was that they leukapheresed from HLA-A2 negative living kidney transplant recipients and then produced the CAR Tregs that is recognizing the HLA-A2. And at the same time, this recipient received the HLA-A2 positive kidney. And a few months later, they infused this HLA-A2 specific CAR Tregs and looked at the kidney biopsy and then also tried the immunosuppression tapering over 52 weeks, which is 1 year. So we haven't had the published results from this clinical trial yet, but it seems very promising and looking forward to the results in the future. So going back to the polyclonal Tregs, which has the longest history of the Treg therapy. So a couple of years ago, one study, this is multi-center study on the Treg therapy associated tolerance injection, has published in Lancet. So they tested multiple products at various time points, including regulatory monocytes, polyclonal Tregs, donor antigen reactive Tregs, et cetera, and then followed up almost 5 years after infusion. So some of the recipients are able to wean completely off from immunosuppression, but it was very heterogeneous population. It was very, very hard to draw a solid conclusion from this one study. So, but their clinical results looks okay. They didn't have much biopsy-proven acute rejection, as you can see on the left. And then interestingly, if you compare the regular therapy in orange and the cellular therapy on the blue, the cellular therapy group on the blue had lower infection and the infection-like manifestation, which is likely due to the reduced dose of global immunosuppression. So that's very interesting. And based on that finding, the group moved on to another clinical study called a 2 study, transplantation without over-immunosuppression. This is a phase 2 randomized controlled trial of delayed administration of autologous Treg therapy in a living transplant. So in this study, this is very standardized protocol, which is great. They expanded the polyclonal Tregs in the in vitro and ex vivo expanded by CD328 stimulation in the presence of IL-1, IL-2, and then sirolimus. And they cryopreserved the Tregs until use and infused the cells at the 6 months time post-transplant. So this is the protocol of the clinical output, and late treatment at the 26 weeks after transplant with the induction using alemtuzumab. And there was no graft loss or patient mortality throughout the follow-up period. So that was recently published last year. And they, after the COVID pause, they revised the induction therapy from alemtuzumab, which is Campath, to the basiliximab infusion. So the revised protocol is still ongoing, but hopefully we'll see the results in the near future. So lastly, I'd like to touch briefly on the CAR-T used for the autoimmune disease such as lupus or desensitization. So CAR-T cells are recently started to use to treat the autoimmune disease as well. So on the left-hand side, it's kind of highlight figure from Nature Medicine using the CD19 CAR to treat the refractory lupus, inflammatory myositis, or systemic sclerosis. They included 15 patients with a 15 months follow-up. They showed improved clinical scores, as you can see here, SLE-DI and anti-double-strand DNA, and also urinary protein. So that is also promising use of the CAR-T cells in the autoimmune setting. And then also in the transplant field, CAR-T therapy are started to use in the sensitized patient. So the University of Pennsylvania group used a combination of CAR-T targeting CD19 as well as the APRIL, so that these CAR-T cells can target the B cells that are, or long-lived plasma cells that are producing the anti-HLA antibody. And using the islet transplant mouse model, they showed a prolonged islet survival in the mouse model, as well as a decreased anti-HLA antibody in myeloma patients. So this is the blood glucose trend of the mouse islet transplant model. So if you're not treated, these animals remain diabetic. But if you and then also if you treat them with a CAR-T targeting CD19, they also remain diabetic. However, if you give the combination of CAR-T and BCMA CAR, the APRIL CAR, together, the type 1 diabetic animal who got the islet transplant remained non-diabetic for a long, long time. So this sounds very promising, and I think it'll be ready to be translated into the human clinical trial as well. So another group from Mayo used the BAFF receptor antibody and CD28 and CD3 zeta product to test the efficacy in ex vivo to suppress the B cell producing anti-HLA antibody. So this is a little bit preliminary data compared to the previous one, but it seems that this BAFF targeting CAR-T therapy might be another option to desensitize the patient in the pre-transplant situation. So here we talked about the cellular therapies that are emerging in the cancer, such as PTLD and then transplant field. And application potential are huge and in both effector and then regulatory arms. And we expect to see more clinical trials and mechanistic data in the CAR-T or VSD or Treg therapies. and then happy to take your question.
Okay. Thank you for the great lectures. If you have any question or comments about this topic, please feel free to ask to her.
May I ask a question?
Yes.
I am DHD study about dendritic cell-based immunotherapy. Yeah. Thank you very much for your good, excellent presentation, Professor Murakami. I have a question, different issue. I wonder how do American scientists study about COVID-19 vaccination? I didn't get the vaccination. If you get the vaccination, the vaccination or not, what is the reason? Please explain to us.
In terms of the efficacy of the vaccine or for the transplant patients or kind of general population?
Yeah. We in Korea we have the vaccine mandatory, but I didn't get the vaccine.
I see.
I wonder, do you get the vaccination or not? And what is the reason?
Right, that's a great question. I think, we do have, each center has different policy about recommending vaccines, but we usually recommend pre-transplant patients get all kinds of vaccines, including COVID or flu or pneumovax and shingles, etc., just to, prevent them from getting the opportunistic infection post-transplant. I think the situation is evolving for the past few years. Of course, right after the pandemic in 2021, 2022, it's very highly regarded to have them get them mandatory vaccines pre-transplant. But for the past 1 year or two, the severity of COVID-19 infection is less prominent. So the institutions tend to be more flexible in terms of the mandatory vaccines. But in general, the COVID vaccines are very effective in preventing the infection as well as ameliorate or make the symptoms less severe even if they get infected. So we generally recommend them. So that's our practice in the United States, or at least in the institution that I work in.
Thank you very much. Thank you.
Dr. Nagwa, thank you for your great presentation. I have a question for you.
Yes.
So given the potential risk of secondary malignancy and infection, what strategies can be employed to ensure the safe and effective application of cellular therapies in transplant patients?
Yeah, that's a wonderful question, especially, for the last month or two, there have been a couple of case reports in New England Journal of Medicine that infused CAR T actually carry some, p53 mutation, and that can become eventually, the source of lymphoma. So I think that's a very important point, and we need to learn, from these cases. And so I think there's more to come. I think, we have been using the CAR T in a very refractory cases. So in these cases, the benefit of CAR T exceeds the risk of secondary malignancy down the road. But now we realize, what exactly is going on in the secondary malignancy. I think we should probably do more, preventive measure or monitoring after CAR T therapy. And then what was the question about the infection?
Yes, the infection.
Did you
Yeah,
did you ask about question about infection
yeah, the
infection in a CAR T?
yes.
Right. So CAR T therapy, before the CAR T therapy infusion, they received the myeloablative chemotherapy, so that will put them at the higher risk of infection. So we usually recommend them to take the prophylactic antivirus and the antibiotics for as if they had received the induction therapy, like a thymo or something. But I think that's necessary because they have very low immune system right after CAR T therapy.
Thank you.
May I ask question another?
Yeah. Yes.
Yeah. How is the lifespan of a CAR T cell? Average lifespan.
That's a great question. So we don't have the data for the transplant recipients, but in the non-transplant recipients, there are probably 6 months to 1 year. They in the for example myeloma field, they serially check their specific, the PCR fragment of the CAR T, and they were able to detect their CAR T product up to 1 year.
Oh, okay, thank
Yeah.
you very much.
So that's a very important point because sometimes we see patients with ESRD on dialysis due to myeloma and who had received the CAR T. And now these patients are coming to the clinic to receive the kidney transplant. So the hematologist said, what kind of induction we should use, and then as a transplant nephrologist, we may wonder that if we use thymoglobulin, these T cell depleting induction therapy might, wipe out or kill the previously administered CAR T cells that might be circulating in the body. So that's a very important point, and I think we should gather more data in a pre-transplant and then post-transplant situation as well.
And then the therapy is the term is 6 months or CAR T
So
cell. One time,
yeah,
only one
CAR
time.
T cell is just one time.
Yeah. Okay, thank you. Okay, thank you very much.
You're welcome.
May I have a question?
Yes.
How does the number of T cell used in CAR T therapy compare to the number of T cell originally present in our body?
Yeah, that's a good question. I think it's the number of the cells are very, very small compared to the whole T cells in the body. I think they have to look back, but hold on. Yeah, they didn't specify, but it's per kilogram basis, maybe 1 million or I need to check the data, but 1 million per kilogram or so. So it's very tiny number of T cells compared to the T cells in the whole body.
You slide 10 to the 9th power, maybe.
Okay.
Yeah.
Is that for the CAR T?
Yeah.
Right. Yeah.
Dr. Naoko, I have a question for you too. So, based on the recently research and data, so what are the main challenges of using CAR T therapy in kidney transplant recipient, particularly concerning immunosuppression and the graft survival?
Right. Yeah. So I think the immunosuppression management is the most challenging part because it's, in order for the CAR T cells to be functional, you need to minimize the immunosuppression, but that will put the patient at a higher risk of rejection. And so we tend to use only prednisone 5 milligram at the time of the leukapheresis, and they tend to do okay in terms of the manufacturing CAR T cells. They need to pass the quality control at the manufacturer, but they are usually okay when they're on a prednisone 10 only. And also, it seems like if we use a Cytoxan as a part of the myelosuppressive, myelodepleting therapy before CAR T infusion, that probably buy some time for us to prevent the rejection, because it can work as an immunosuppression as well. So in the very early experience in CAR T cell therapy in the kidney transplant, I think the WashU team published in 2009 or 16 or 17, they didn't use the Cytoxan. They used the fludarabine only for a mild-ablative pre-treatment. And then these patients tend to get rejection after CAR T infusion, likely due to the minimized immunosuppression. So I think using the Cytoxan as a part of the ablative induction therapy is another important point that we should keep as a protocol.
Thank you.
Is there any more question?
There are so many cellular therapies expanding, as a therapeutic option. So I think there will be a lot of the research and the clinical trials in the coming years, and we're super excited to see them. Yes.
Excuse me. Ex vivo, how is the culture days in ex vivo expansion, CAR T cells?
Yeah, it's usually 2 to 3 weeks,
2 to 3 weeks.
including quality control and so on. Yep.
Okay,
So
thank
that's
you.
another important point. So if they need the emergent therapy, especially for worsening, progressing PTLD, they don't want to wait 2-3 weeks, right? So that's another challenge to overcome.
At the culture, you don't insert any dendritic cells at the CAR T cell, no?
Not in the CAR T cell culture. They transduce the T cells with the engineered receptor, and then they use the cytokine stimulation to expand them, likely IL-2 and CD3 and 28 stimulation. Right.
Okay,
So they're
thank you.
not antigen specific, so they don't need antigen presenting. But in the T cell expansion, if you want to expand the donor specific Tregs, they do need dendritic cells in the culture to expand the antigen specific Tregs.
Okay, thank you.
Yeah. Do you use the donor derived dendritic cells in your research?
Yeah, leukapheresis, peripheral blood mononuclear cell, and then I use FGIT, FLT3 ligand, GM-CSF, IL-4, TNF alpha, and the course 2 weeks.
2 weeks.
And and then PBMC converted to dendritic cells. So we harvest the cells and then infuse to peripheral blood at the patient.
Gotcha.
At that,
So it's
at that time we have tumor antigens, tumor tissues, focals.
I see.
Yeah.
Gotcha. So it's more of the like a tumor treatment rather
Yeah.
than tolerogenic. Okay.
A kind of adaptive immunity, immunotherapy.
Gotcha.
Yeah.
Yeah, that's very interesting.
Okay. If there are no more questions, we'll close this seminar here, and she must go to sleep. Yeah.
Thank you.
Dr. Murakami, we
Thank you so much for
hope-
having me. It's a very wonderful session. And then if you have additional questions, please do feel free to email me. I'm happy to.
Okay, thank you. Thank you very much. We hope for great success in your research. Thank you for your great lecture again. Thank you.
Thank you very much.
Thank
Thank you
you.
very
Thank
much.
you all.
This is Murakami.
Yeah.
Yes, thank you. So this
You're
has
welcome.
been an invaluable opportunity to gain the latest insight in the CAR-T therapy for kidney transplant recipients. So I would like to conclude with several announcements. 1 second. Once again, we would like to express our sincerely gratitude to Professor Lauka for delivering today's the lectures. In April, instead of the regular research, regular seminar, the second symposium of the Korean Society for Nephrogenic Disorders will be hosted by our hospital. We engaged you to attend either in person or online. So, just kidding. So as we sign off, remember take care of your organs, and they will take care of you. Stay curious, stay inspired, and you will see you in the next seminar. Have a nice weekend. Thank you. Thank you so much.
Thank you. Sayonara.
Thank you.
Murakami.
Thank you.
Bye.
Welcome.
Thank you.
night.
Bye-bye.
Bye-bye.
Good night.
Bye.
Bye.